Good afternoon, everybody. You're very welcome to this important session at the end of a busy day. During the lifetime of this current council, I've had the honour of being the chair of the Council Research Committee, and we've done a lot of work in cooperation and leadership, particularly of the President, Professor O'Connell, who I'd like to acknowledge in terms of his contribution to this overall. And I'd like now to introduce the session on the Research Committee and the output. And one of the great outputs is the commissioning of a national network and a national surgical research support centre. And I'd like to introduce Professor Stewart Walsh to give his talk as the initial lead of the RCSI National Surgical Research Support Centre. You're very welcome, Stewart. And Stuart's going to talk on surgical-led trials. Over to you, Stewart.
Lovely. Thanks very much, Michael. I'll just share a screen here, hopefully. And okay, so I'm just going to speak briefly this evening about the new Surgical Research Support Centre. I'll tell you a little bit about what it is that we're offering, and I'll also tell you a little bit about the direction of travel, say, over the next sort of couple of years. I mean, it's an interesting time at the moment, I think, in surgical research. You know, we're here in 2022, and internationally and nationally, funding agencies, be they health insurers or be they governments or health boards, you know, they are moving away from sort of accepting expert advice in terms of procedures that should and should not be offered, towards requiring sort of very robust data to support the, you know, both the introduction of new procedures and increasingly the continuation of procedures that have been around for a long time. So there is, I think, a little bit of an onus on surgeons now to start thinking about how we engage in the world of trials. And traditionally, obviously, Ireland, you know, has always punched above its weight when it comes to surgical research. That has largely been, you know, surgeon researchers undertaking high quality research, but sort of within silos, and like successful sort of output in the clinical trials arena. You know, that's a very difficult thing to achieve for an individual surgeon researcher. It sort of requires collaboration and cooperation. And I think in some ways, the more important sort of talks over the next half an hour are actually going to be from my two colleagues who are going to talk very much about the importance of collaboration and cooperation in driving high quality surgical research in 2022. This slide, I think, just illustrates the increasing importance of clinical trials in the totality of medical research. This is some work that our SPR, Natalie Doolan, very kindly did for us a couple of months ago. She's with us down in Galway at the moment. And Natalie's been looking at the numbers of trials being undertaken. And yeah, I mean, you can see here quite clearly, like there's been an exponential increase in the number of trials over the last 20 years. It really took off after about 2006, when the International Committee of Medical Journal Editors mandated that trials be registered in advance of being published. And it's really just like continued to surge since then. Most of the trials, though, you know, are in all sorts of interventions, and only surgical trials account for sort of less than 10% of this. Natalie went on to then look at Irish surgical trials. And so by this, I mean trials registered on clinicaltrials.gov, in which an Ireland-based surgeon was the chief investigator. And those results are presented here. Now, actually, when you take away the observational type studies, which were also being logged on clinicaltrials.gov, and look at the RCTs. The RCTs are the red data points. I mean, I don't think we need a statistician on the call to sort of see that the line of best fit for our red data points is sort of going to be a flat line running in parallel to the horizontal axis. So while the rest of the world maybe is in a phase of exponential growth in surgical trials, within Ireland, you know, we're pottering along, but we don't seem to be displaying the same exponential increase. So there's maybe a bit of a danger that we might be sort of falling slightly behind on this. And I think, you know, to its credit, the College in Surgical Affairs have recognised this, and the work that Professor Kerin has led and Professor O'Connell have led over the last few years resulted in the report from the Short Life Working Group. And this very much has become our Bible within the Research Support Centre over the last 2 to 3 months as we try and get things moving. There's a number of recommendations in it, and you know, we can't address them all instantly, but we have to make a start somewhere. And I think, you know, when we sat down and we went through this, the core recommendations were around, as Michael just said, the establishment of networks. So, you know, there's a requirement to establish a national clinical trials network, which is why we're initially putting some emphasis on trials. We need to support the ISRC, and we need to promote engagement with international trials networks. Although realistically, to engage internationally, we need to have a functioning network on the island to interact with. And so again, when you take these recommendations and you take another little sort of step back down from it and drill into it, really the cornerstone of it all is that recommendation 3.1, which is to establish a national clinical trials network for surgery. And we're putting a lot of effort at the moment into trying to get this cornerstone sort of positioned and bedded in, so then we can start to build the other blocks of activity around it. And you know, it's important to say at this point, it's not a case that the only thing that the Research Support Centre will support is trials. It's not. You know, we're here to support research in all its forms, but we have to start somewhere, and we have to put our shoulders to the wheel somewhere. And we're starting with this recommendation because we feel it is very much the vital sort of cornerstone of it all that we're going to have to build on. You know, I think a lot of people on the call will have had the idea to perform a trial. And, you know, let's say you have an idea, you think, well, how about we do a trial to compare using a scalpel versus using a diathermy blade for the skin incision in dynamic hip screw operations? And it sounds simple enough, doesn't it? You know, and you're sort of sitting in a room and it sounds simple, and then you walk out of the room and you enter this sort of labyrinth of red tape. And people start asking you all sorts of questions about this trial. You know, who's going to sponsor it? Does the HPRA need to approve it? Does the Medical Device Directive apply? You know, have you sorted out a data controller? What about the GDPR issues? You know, all these things come up again and again and again. And I think in a lot of cases, you know, people start on the journey of thinking we're going to undertake a trial, and the red tape gives them such a headache that they end up going, you know what, this is all just too much hassle. And a lot of really valuable trials never get off the ground because people get lost in the red tape. And I think this is where the support centre can come into play very much. You know, myself as the clinical lead, and Anne-Marie Byrne, who's our programme manager, you know, between the pair of us, we spent years navigating through this red tape around clinical trials that we've run, that we've helped run. You know, we know our way around this. So rather than trying to do it from scratch yourself, you know, please come and talk to us. We can help shepherd you through all of this and try and take a lot of the pain away from it. And that, I suppose, is how we see the support centre acting in the next couple of years. We're very much trying to set out to provide almost a backroom support to people undertaking clinical research in general and clinical trials in particular, to help around trial design, protocol development, navigating the regulatory morass, helping with ethics, helping with data management. these types of things. So, you know, this is the foundation we're trying to build it on. We're just trying to take some of the pain out of it for people who want to undertake clinical research. And in doing so, the idea is that we then catalyse more clinical research activity, and specifically at the moment, more clinical trials activity, because that does have a longish lead time in terms of showing results. It's not the only activity that we're going to be engaged in. There's a lot of other activities, there's a lot of other things that we can help with. But, you know, to get the ball rolling, we're starting with trials. And we have a few things coming up just in the next couple of weeks, just to highlight to you and take this opportunity to highlight to you. Kicking off, for those of you who sort of think you want to undertake a clinical trial, but aren't entirely sure where to start, we've collaborated with the HRB's Trials Methodology Research Network, and we've lined up a couple of very well-regarded speakers from the UK who have enormous experience in undertaking clinical trials. And we also have a couple of Irish surgeons who have successfully completed multi-centre and single-centre randomised controlled trials as part of their MD projects during their higher surgical training. So, you know, we hope that that'll be a very useful session. It's about a 3-hour session on the 11th of May. Everyone is welcome. We would encourage you to join it if you're interested in trials and if you're thinking about heading down a trials direction. I think that will be useful for people who are thinking then of engaging with this. So we're about to issue a feasibility trial award scheme. Now, for those of you not sort of entirely sort of familiar with the jargon, a feasibility trial is a smaller trial that you do in advance of a full-scale trial. And it considers issues like whether recruitment is feasible, whether or not a proposed intervention can be replicated on several sites, whether or not you're able to use some form of surrogate marker to get an idea as to whether or not the intervention might actually show a reasonable effect in a large-scale trial. I'm not going to go into all the details of it here, because the details are going to hit everyone's email inboxes in the next couple of days with this. But, you know, if you're sort of sitting on the call and you're thinking you have a trial that's about to launch, or you're thinking that you have a trial that you would like some help getting off the ground, you know, we would encourage you to consider this. You know, the support centre will provide help in terms of ethical and regulatory support. We can provide help with designing the protocol. We'll set up data management for you through REDCap. If you need trial sponsorship for non-regulated trials, we can arrange that. And there is a little bit of funding with this for things like publication charges, for trial protocols, for helping with small running costs and small equipment costs, paying for third-party randomization, etc. We can fund that. Before anybody asks, we can't fund research nurses because there'll be no budget left if we do that. But we are keen to try and help as many people as possible get some feasibility trials off the ground. There is a little bit of self-interest in this. You know, we need to establish a pipeline, if you like, of trials that might ultimately be able to obtain some form of external funding. Because while, you know, Surgical Affairs has very generously funded things to get things off the ground, obviously we do have to think about the long-term funding strategy for this, and part of that is going to be around obtaining external funding for trials, some of which can then be used to support the activities of the support centre. So that'll be coming up. It should be in your inboxes in the next couple of days, hopefully. The other thing, just to draw the attention, particularly of the trainees too, is we're also going to put out a call for applications for a trials research fellowship. So part of the remit of the centre is to provide training in clinical research methodology, and we felt this would be an appropriate thing to do and would help advance that. So the idea is that over the next 3 years, we will have 3 fellows each appointed for a year. So we'll put the call out on a yearly basis. The fellow is open to any surgical trainee from any discipline who wants to apply. They can either undertake their own trial if they wish during that year, and we'll support them in doing that, or they can undertake some trials methodology research if they prefer. And if they want to register it for a higher degree, we'll support them in that. Or if they want to undertake a master's in clinical research methodology, we'll support that. So that'll be coming up again in the next few days. And in all of this activity over the next sort of couple of years, the aim very much is to try and create the surgical trials network that was, mandated in the recommendation from the Short Life Working Group, and to try and ensure that that fits in and links in to the existing infrastructure that has been created in Ireland around clinical trials. And you can see that there is a distinct lack of anything surgical in this at present, and we very much want to create something that is self-sustaining and links in with what is already there. And the key to that, I think, as we're going to hear from the next couple of speakers, is collaboration and cooperation. That this is not a single surgeon game. This is something that, as a community of surgeons, we will have to work together to try and deliver. And I'm very optimistic and very hopeful that we can achieve exactly that over the next few years. Thank you very much for listening, and I'll hand you back to Professor Kerin as the chair.
Thanks indeed, Stewart. And now I would not want to delay proceedings, but it's a great pleasure to introduce Christina Fleming, who is the Progress Women in Surgery Fellow supported by Olympus Medical, and a Robotic Colorectal Surgery Fellow in Bordeaux. I'm looking forward to meeting you at the European Surgery Association next few weeks, Christina. But as an advocate, chair and lead for the Irish Surgical Research Collaborative and a hugely successful ambassador for Irish surgery, it's a great honour for me to introduce you to deliver a talk which is on your slide here, on your first slide. So over to you, Christina.
Excellent. Thank you, Prof, for your very kind introduction. I hope you can see my slides okay, and that the sound is also fine. So I'm going to talk a little bit today, as the title outlines, that collaboration is the new competition. And really what I want to touch on are a few things, including the trainee research collaborative model, which we've now adapted here in Ireland as well, the rationale for creating and developing such an environment for trainees to perform research, how we as a group evolved, certain obstacles and pivots that we had to take along the way, and where we see this going in the future. So I think we're all well aware of the history of surgical training research collaboratives, which were very successfully commenced in the UK almost 15 years ago now by the establishment of the West Midlands Group under the stewardship of Professor Dion Morton. And since that time, this model of research delivery has really increased. It has facilitated really high quality patient-centered research. And whilst it commenced in the earlier days at a cohort level of research trial methodology, it has subsequently gone on to deliver some really impactful randomized controlled trials, which are really impacting practice. But even furthermore, I think we can say the establishment and delivery of COVID search research has also impacted on public health policy. So this is a very powerful research delivery method. So with that in mind, the rationale in 2015 was to consider, could we deliver this model of research in Ireland? And it's important that I mention four really important people in this process who were involved in the foundation of the group, including Helen Mohan, Jarlath Bulger and Frank McDermott, as well as Michael Boland. So we had some informal discussions about whether, a research collaborative is something that would work or would be of use in an Irish surgical research context. So I guess, what was the rationale and was there a need for such a model? So we have some data from trainees both in the Republic of Ireland and Northern Ireland on what are the unmet needs of trainees when it comes to surgical research. And looking at the qualitative fields, these are some quotes that I pulled out that I feel support why having a trainee collaborative is actually of value. So if you look at the first one, sometimes there can be an unlevel playing field with research opportunities, and that can be based on geography or it can be based on surgical specialty. In certain, I guess, situations, there can be a lack of formalized or supported pathways for research delivery. And I think the third one will resound with a lot of us, that often, you know, we need to do, or we perceive that we need to do research to progress. And yes, research is important, but by actually pooling expertise and pooling resources, we can deliver a higher quality research that has far more impact for patient outcomes. So that's looking at the unmet needs of trainees, if we further look at the unmet needs of surgical patients, and here are some really important salient issues in the delivery of surgical care that are affecting us in the current era. And on the right, I outlined some patient-reported outcomes. So we're now looking at not only, you know, how do we design trials, but how do we measure success in trials? And all of these areas are areas within which the model that we have participated in has allowed us to deliver high quality research to date. So when we talk about the research ecosystem, really we're talking about, you know, who are all of the important stakeholders that are involved? Well, obviously there's the, you know, the patients who are the most important stakeholder in the entire process. But then, you know, there's those who want to perform research, the surgical trainees and trainers, those who have research very much at the center of their ethos, the academic institutions, and then research support groups. So looking at the HRB and the newly founded National Surgical Trials Support Centre. And really, how can we bring all of these things together and connect them through collaboration to deliver all of the different types of research that we're interested in performing and that have an important place in surgical practice. So if we look at the evolution of our group, as mentioned, we started informal discussions in 2015. So bringing that up to 2021, you know, we have delivered our first study, which was just a national audit. I'll discuss in later slides. But if I were to pick out the most, I guess, impactful points in this process, is firstly coming up with the idea that this is something we wanted to embark on. Secondly, it was developing an organizational infrastructure and a committee where we actually had some quality assurance and some formalized management of the entire process. Then the next thing was getting really important support from well-established organizations, including RCSI, who've been very supportive of us throughout this process. Then it was developing a robust data management method, and obviously with the support of RCSI and REDCap, that has allowed us to deliver the research that we're doing at the moment. And then moving on to funding. So in 2019, we received 2 grants, and in 2021, we received our 3rd grant. So the point that this has brought us to now is we've delivered, you know, a national collaborative study, a global collaborative cohort study, and now we're moving on to deliver randomized controlled trials. Whilst it seems like, you know, it took us a very long time to do that, I think a lot of the time the progress seemed quite slow in the beginning, but once we were able to build momentum and get the right support and infrastructure in place, actually the development has been quite exponentially increased. So as mentioned, this was our first study, and I think it's important to talk about this because we learned a lot from what, you know, was a very small national cohort study that only included 94 patients, but those 94 patients were recruited from 17 hospitals in Ireland and involved over 70 collaborators. So what this allowed us to do was to test the model of, you know, can we all work together, gather data over a certain period of time, put it together and actually deliver a project out of it? And the answer was yes, we could. And this brought us on then to, you know, can we do this beyond Ireland and in a more global setting? So the retainer study, which Stefanie will talk about in far more detail, you know, it closed to recruitment in October with over 4,000 patients recruited from over 35 countries. So, you know, by building that smaller model, we were able to build further on that to test the methodology and bring it into a more global context. And the second part of this study now is looking at using a completely different research methodology of can we develop, you know, a patient-reported outcome measure in qualitative research. The current opportunities within the collaborative and what we're focusing on at the moment. Currently, Zara Kennedy has in progress a randomized controlled trial in metabolic surgery, looking at thromboprophylaxis in the preoperative period. And Caroline Cullinan is leading on a perioperative obesity quality improvement project in parallel to that. So very different kind of research methodologies involved in both of those projects. And we have three further projects in planning phases as well. So to talk about the pivots and things that I guess we learned along the way, we recently published this article in ANZ Journal of Surgery, and it allowed us a really good opportunity, I think, to reflect on the lessons that we've learned, what has worked and what hasn't worked, and what mistakes we probably wouldn't make again going forward. And I think the first thing is, you know, when you're starting a research project, you kind of want results straight away, and particularly if you're funded, because your funders want to see, well, what are you doing? But I think, you know, setting very realistic time and project management outlines from the beginning are very important. Data management is crucial. And I think, you know, with GDPR, sometimes we can be afraid of data, but I think we need not fear data. We just need to ensure that we have a very robust mechanism in place for data collection and data protection that is in compliance with all of the recommendations that are out there, and working with support groups like the Surgical Research Support Centre is really where there's huge benefit from this. Communication is really important. So, you know, not just from the point of view of emails, but social media, having a website, regularly updating it, and particularly when moving beyond the boundary of Ireland and into the global, creating a global collaboration, you know, having, you know, very visible promotion of the work we were doing for recruitment was crucial to the success of recruiting hospitals from over 35 countries. We obviously, there's a lot of curveballs along the way, and I think the pandemic was one thing that really tested resolve, and I think Stefanie will discuss it in much more detail. But at the time, we had a study that was funded that was not deliverable, and we never actually knew when we could deliver it. But I think we learned a lot about just having a bit of resilience and staying calm and having very clear communication with everybody involved. And then when the time was appropriate, we were actually able to go ahead and deliver the study, and it's been a huge success. And the final thing I think to reflect on is sustainability and flexibility. So sustainability from the point of view, I think, of our group is the people that are involved, and ensuring that you have people involved with from different backgrounds and who bring a very different perspective to the table, but also that there's some flexibility. So this is the outline for our incoming committee, which will be formally in place from our AGM on Saturday. And we've really focused and transitioned a lot of the roles within the group to project leads, because now that we have, I guess, you know, developed and optimize the process somewhat, we now want to really ramp up the productivity, and we feel in a good position to do that with the support of the Surgical Trials Support Centre. So with regard to future growth, and a lot of this Prof. Walsh has touched on, so, you know, having trial support centrally and locally, you know, having that central hub that can advise and provide the important pathways and support that you need to deliver the research on the ground is crucially important. Having higher degree opportunities, and I think the announcement of having a research fellowship is fantastic. It's exactly where we would want to see those opportunities opening up for trainees who are interested in research, and in particularly in delivering clinical research and surgical trials. I think something that we've discussed about before within the forum is, you know, how can we further professionalize trainee-led research, and you know, thinking about that, you know, a lot of higher degrees are now undertaken quite early in training, sometimes even after intern year. So you can have a PhD but still have all of your surgical training to do. And how can you continue your academic role in that environment? How can we create opportunities for, you know, co-PI roles for surgical trainees? And I think, you know, as Prof. Walsh announced, having the feasibility trial scheme is an excellent example how we can create funding opportunities for trainees to, you know, design and deliver trials and continue the professionalism of their academic career in parallel to their surgical training. And the last point, I guess, is on transparency and maintaining competitiveness. So this is something that we've been really focused on within the collaborative, because obviously, you know, the whole point of having an inclusive network is that everybody should have the same opportunity to contribute. So, you know, we have mechanisms in place to ensure that from the point of view of our committee, and also from the point of view of the projects that we select. And it's something that we will continue to remain committed to as well. So in summary, I think the trainee research collaborative model is a very good example of how you can create an inclusive research ecosystem where all trainees have access to do research, regardless of where they're situated geographically or stage of training. It's a really good opportunity to match the unmet needs of patients and the unmet needs of trainees who are interested in doing research. It also allows you to explore multiple types of methodologies in research design and delivery. So we've moved from cohort studies to a randomized controlled trial, and now we're touching on quality improvement and quality assurance. What that also does is it allows us to develop skills within all of these research methodologies, which will further enrich the methodological quality of the surgical workforce going forward as well. And I think the last point to talk about is just support and sustainability. So we're very grateful for the support that we received from RCSI so far, and from our funders, the European Hernia Society and the British Hernia Society in particular. And it's really important that we continue to make this an attractive option and mentor and support more junior trainees as they come through the ranks to get involved, and hopefully they'll gain a lot of research experience, mentorship and leadership opportunities through it as well. So thank you for listening, and hopefully you'll have some questions at the end.
Thank you so much, Christina, for that excellent overview and how time flies and how much you've achieved in the last 6 years. So very well done. And now I'd just like to move on to Stefanie Croghan, who's the project lead for Retainer, and has had a fantastic time in doing this international study led out of Ireland. So Stefanie, congrats on your incoming co-chair role for the collaborative, and we'd love to hear your talk on the lessons learned from Retainer.
Thank you very much, Prof. Kerin. I'm just going to share my screen here. Is that projecting okay?
Yeah, it's good.
Yeah, that's all good.
Great, thank you. So good evening, and thank you for the opportunity to speak briefly this evening on lessons learned from the delivery of Retainer 1. I'll keep it brief, I know it's late in the evening. So Retainer 1 was a project delivered by the Irish Surgical Research Collaborative that Christina has already very eloquently described this evening and discussed the evolution of. Retainer 1 stands for Retention of Urine After Inguinal Hernia Elective Repair. And this was an international prospective observational study delivered by the ISRC, as mentioned, and the data collection has recently been completed. So a brief talk outline, I'm going to just touch on the background, summary of results and conclusions of the Retainer study itself, but mainly focus on the evolution and the methodology and the lessons that we learned along the way and the mistakes that we made and how we could be better guided for future studies. The rationale behind Retainer 1 is that postoperative urinary retention affects a significant proportion of male patients following inguinal hernia repair. And this is very well known anecdotally. The international literature had reported a very wide range of an incidence of 0.4% to over 40%. And this is very significant for patients in terms of distress, in terms of complications with risks of catheter-related trauma or infection, and from a healthcare economic perspective, in terms of financial and logistical burden, for example, with unplanned admission from day case surgery. We aimed to evaluate the incidence of acute urinary retention following elective inguinal hernia repair. To do this within a collaborative framework, and to identify underlying risk factors for acute urinary retention in male patients following elective inguinal hernia repair. And Retainer 1 was very much an evolutionary process. So it started as an idea, became a draft protocol, was presented to a Dragon's Den hosted by the ISRC, gained the support of the ISRC, went on to gain further support from the Royal College, for which we're very, very grateful, including facilitating use of REDCap. Went on from there to get our first grant from the European Hernia Society, and then evolved into Retainer as we know it, and we'll further discuss this evening. The design was multicentric, including all consenting adult patients undergoing open or minimally invasive elective hernia repair, with standardized data collection focusing on pre, intra and post-operative variables, and all collected via REDCap. So I'm going to discuss briefly the methods with the steps and the timeline and the lessons that we learned. So we began with a pilot study in 2019 and protocol refinement, and we found this extremely useful to identify teething issues, to test the soundness of the data collection methodology. And really this is something that I'd emphasize we learned a lot from, because no matter how many times the steering committee have looked at the protocol, I suppose you can be over familiar with it and maybe not identify things that aren't quite clear to data collectors on the ground, or errors that might be made. So we found this really useful and refined the protocol with a few small changes on the basis of that. We also used this time to seek funding and grants, and to link in with the college, who were instrumental in providing resources, most particularly REDCap and statistical support, which allowed us a formal statistical review of the power calculation, and then allowed us to begin with REDCap from the get-go, which was instrumental with international collaborators involved. We then began to recruit centres. We found it useful to recruit locally in the first instance, to, I suppose, gain momentum and be confident that there would be buy-in and that people would be keen to get on board. And we recruited early, and again began at that point to seek ethical approval processes, and certainly ethical approval was a challenge in some centres, not so much in terms of having anything controversial within the protocol, but as everybody knows, there is various delays and huge burdens and demands on local ethics committees. So one thing we've learned is the importance of seeking that as early as possible in all centres, and also to have as tightly finalised a protocol as possible to minimise the number of amendments or clarifications that might be required. This hopefully with national ethics will become a more streamlined process. But having said that, there's still the question, if you're recruiting international centres, that they may or may not have international processes or national processes, so it needs to be achieved early. We then launched data collection, and that was in 2020, very early 2020. And as Christina briefly touched upon, we really learned here about unexpected obstacles that may arise. So COVID-19 had certainly not featured in our plans, and really, was quite jarring because it occurred in the first instance as we were launching, which was quite disillusioning, particularly in the context of delivering an elective surgical study on inguinal hernia repairs. Of course, not being cancer surgery, we're never going to be a priority throughout the pandemic. So I suppose what we mainly learned from that was, I suppose, to stay determined and just try to be flexible. And I think it was useful for us to have had this experience. So we brainstormed a lot within the collaborative about how to approach that. We decided to pause data collection rather than have a very prolonged period of very slow data collection, which we thought would lead to a loss of momentum. So we decided to take an official pause, which I think probably was the right thing to do, and attempt to relaunch at a later date when things would be better. We did use this time to try to continue to engage collaborators, because we had recruited centres by this point, both in Ireland and internationally. And so we did a snapshot study exploring the impact of COVID-19 on elective inguinal hernia repairs within their centres, which we published in BJS as a research letter. And that was a useful way just to keep in touch with collaborators, and I suppose show them that there was still energy behind the collaborative and behind the study, and to keep people interested. It is, of course, tricky when pauses like this happen, particularly given these trainee-led studies often involve trainees changing jobs every July or whenever the changeover is in the given country. So that's something challenging to navigate, and I certainly would not suggest planning a study to cross a changeover period, but I guess it's possible, as we discovered, where essential. We also tried, I suppose, to see a challenge as an opportunity where possible, or seek that silver lining. And we did use the pause to expand recruitment and to encourage everybody to seek their ethical approval and make sure that that was all finalised. This is our initial recruitment map. Obviously, we started in Ireland, and through the initial period and then during the pause from COVID, we did manage to recruit very globally, and the extra time, I suppose, did help us to do that. So there's perhaps some benefits, I think, with staying flexible and seeking them. We relaunched data collection in March 2021, and the pandemic, of course, was not gone at that point, as we had perhaps naively hoped that it might have been. So I suppose things had settled to the point that it was feasible to recruit some elective inguinal hernias, and we decided to go ahead at that point. But we did still incorporate a flexible data collection period in which we said centres needed to be enrolled for a minimum of 4 weeks. That needed to be consecutive, but we did give them flexibility in when they could do that over a 4-month period, and allowed them to, if they had to pause or something like that, to present extenuating circumstances, and we tried very hard to allow all enthusiastic collaborators to participate and to be eligible for authorship. And there's just some further points. We found really the communication during this was imperative. The volume of communication was extremely high, and I think we learned a lot from that in terms of structuring the committee and having enough manpower on a communications front to stay in close liaison with all collaborators. And then as we come to the close, and we did close data collection in November 2021, and then spent some more time chasing data to finalise records and things like that. But we found this time useful to plan data analysis. We've had many meetings and much collaboration with the statistical department in RCSI, which has been extremely useful for us. And we learned as well, I suppose, one of the unique things about collaborative research is that the author list can be quite immense, and actually quite a challenge to compile. And it's obviously imperative that all collaborators are acknowledged and acknowledged appropriately. So we found REDCap very useful to gather the list via. And one thing we learned was that use of an ORCID for every collaborator helps to keep things clear. But we would certainly have learned from that to start preparing the author list, even whilst the data collection is ongoing. So just briefly to touch upon results, we recruited over 4,000 patients from 205 centres across 35 countries and all 6 continents. Data was ultimately contributed from all of the following countries. And excuse me, to briefly touch upon the results, the male to female ratio was 13:1. The mean age was 54.9 years. 42% of patients underwent general anaesthesia, and 48% spinal or epidural. So laparoscopically, just going back, sorry, there's an error in where that was pasted, but 80% approximately were performed open, 16% laparoscopically, and 0.6% robotically. Mesh was used in more than 90%. The primary outcome was postoperative urinary retention, and in all-comer male patients, the incidence was 5.8%, which is about 1 in 17. Preoperative risk factors that were identified were a previous episode of acute urinary retention and a diagnosis of benign prostatic hyperplasia. We found that in terms of intraoperative variables, performing bilateral hernia repair increases the incidence, as does bladder involvement in the hernia. Transient catheterization, which was an interesting one, where a catheter is inserted at the start of the procedure and removed at the end. Drain placement and the use of local anaesthetic appears to be protective. preoperative constipation was also a risk factor, and a higher preoperative IPSS score, which is the International Prostate Symptom Score, which is a questionnaire we use really to identify obstructive urinary tract symptoms. A higher score on that, as expected, was associated with a higher incidence of retention, quite remarkably, or quite dramatically. Time of day also appeared to have an increased incidence in evening procedures. There. So that's just a brief overview of the results, because mainly we wanted to focus on the methodology and the collaborative itself. So in conclusion, I think collaboration can produce a research project that's greater than anyone's individual capacity, and the ability to expand data sets and to be sure of achieving adequate power is of particular relevance to small countries like Ireland. So we hope to see a lot of collaboration on the Irish research landscape going forward. Collaboration does also, as evidenced in Retainer, allow capturing of diverse populations and to ensure therefore that the research output is widely generalizable. And there are unique challenges, and we must learn how to navigate these as smoothly as possible. And hopefully the work we've done to date has begun to teach us some lessons that we can further capitalize upon. The ISRC work to date does confirm feasibility of large-scale Irish-led collaborative research, and we think the future is very, very exciting. Our next steps with regard to Retainer are to work on Retainer 2, which is more of a qualitative study looking at patient-reported outcomes following inguinal hernia repair, for which we simultaneously recruited during Retainer 1. And we have several other projects that Christina so nicely discussed with the ISRC. Excuse me. I'd like to thank our funders, and I'll just finish with this quote, which I think really nicely encapsulates the ethos of collaborative research, and it also reminds us all that it's worth the initial investment and allocation of resources to create that product and to go further, even if it takes that bit longer to establish. Thank you very much.
Thank you very much, Stefanie. I think in the interest of time, we don't actually have time for questions because of the continuity of the program, which is a real shame, because I certainly know I've lots of potential questions around where we're going with randomized trials and who's going to win this year's All-Ireland, etc. But I think what I'd like to say in conclusion is I'd very much like to thank the President for his role in the development of the National Surgical Research Support Centre. We've been challenged for many decades indeed in terms of trying to develop a real coherent, structured approach to delivery of surgical training. And I think with the help of Kerin and the RCSI, the collective, right? And certainly we've demonstrated that the Irish Surgical Research Collaborative is incredibly successful, and that there's tremendous value in harnessing the intellect, enthusiasm, and togetherness of bright young people who want to achieve something, which we as a group of senior academics would have failed to do, but you've managed to do just by getting together and pushing this out nationally. And finally, I just want to wish Stewart very well in terms of the National Surgical Research Support Centre, the Council Research Committee in setting up this a couple of years ago and setting up a challenge and developing the report and trying to bring everybody together. I think couldn't have dreamed that we would have managed to put this kind of a structured approach in place. I just want to wish Stewart very well in developing this forward, but particularly to wish the Irish Surgical Research Collaborative every success in moving from, taking control of the world into developing randomized trials. And, this is all very much to the betterment of Irish surgical patient care. The best research leads to the best patient care, and onwards and upwards. And I'm delighted with this session and wish you all the very best. Thank you.